day, everyone. My name is Jennifer Ahern, and I am the Chief Officer and Permanent Secretary in the Ministry of Health and Culture, and I'm extremely excited to be welcoming you all here today for the second day of our 6th annual National Healthcare Conference. How was your breakfast? Did everybody get some breakfast? It was good. Can I get a big thank you for Cleveland Clinic for breakfast? I also want to welcome, we have some Passport to Success students here today. Have they arrived yet? The students are late. Oh dear. And I think we also have some nursing students here as well this morning. Good morning, ladies. Welcome. So we have a packed schedule ahead of us today. Lots of really informative speakers lined up. And of course, this afternoon we have our workshops, our interactive workshops. We've got the 3 different subjects that we're looking at this year. The first one being mental health. Let's talk about it. The second one being end-of-life decisions, some of the most important things to consider. And the third one being beyond medicine, taking a look at non-medical therapies. Now, when you registered, you will have indicated which one of these workshops you wanted to attend this afternoon. And I mentioned last night, if you somebody said, well, they couldn't remember which one they registered for, or if you've decided that you might want to check a different one out than you registered for, that's fine. You can feel free to go to whichever workshop you want to choose, okay? A big, big thank you to our sponsors, Tenet Healthcare. They're our Premium Plus sponsors. Can I get a round of applause for them, please? Tenet have been on board with us since the beginning, and they have been a fantastic supporter of the conference. And without support from our sponsors like Tenet, we wouldn't be able to continue to offer it free of charge for you all. And also a big thank you to Iron Shore Pharmaceuticals for last night's cocktail reception. I hope you all enjoyed that if you were here. We've also got our premium sponsors, the Health Services Authority, DART, BAF Insurance, and Tower. And then we've got Generali Worldwide, who are our Wi-Fi sponsor. If you want to find your Wi-Fi, it's RitzConf Room, I think, is what it is. And the password is Generali, all lowercase, Generali. Okay, so you can get logged on to that. And on the topic of Wi-Fi, I want you to take a minute and make sure that your cell phones are either silent or turned off, please. We don't want them interrupting any of our presenters or presentations, either one. All right. Okay, so we have a lot of sponsors and exhibitors. We have a record number of both this year. I hope you've all had an opportunity to check out some of the exhibitors. We also, don't forget, have the exhibitors in the room next door. We've also got a little bit of a challenge for you this morning called Find the Flu Shot. We do have free flu shots. Last night you would have noticed they were in the room next door. This morning until 10 a.m. they're in the Rembrandt room, which is where you registered. And after 10 a.m. they'll be back next door again. So just to encourage you, please do take advantage of the opportunity to get your flu shot. It is free and it's pretty quick. I got mine this morning with my coffee, so I'm all set. And also don't forget the health check station, which is at this end of the hallway as well. One other thing is the evaluation forms. We really do value the feedback that we get from you. Please take a moment there at the back of the room, fill them out, give us your feedback, give us your suggestions in terms of things you'd like to see us cover next year. We do listen. We really, really do, because the topics that we're covering this year are a direct result of the feedback we got from the attendees last year. So please do take that. Okay, and there's also CME certificates, which can be collected from the registration desk. Okay, I think that's all the housekeeping I was supposed to do before we got started. So again, thank you very much. I hope you've all enjoyed the breakfast, had your coffee, and are ready to go. Our first speaker this morning is Dr. Thomas J. Smith. He's the Director of Palliative Medicine at Johns Hopkins Medical Institutions. And he's going to speak to us this morning about the reasons to do palliative care and caring. Dr. Smith is a medical oncologist and a palliative care specialist with a lifelong interest in better symptom management, open communication, and improving access to quality, affordable care. He is the Director of Palliative Medicine for Johns Hopkins Medicine, integrating palliative care into all the Johns Hopkins venues, including a consult service, inpatient unit, clinics, home visiting program, and research. He attends on the Longcope service of the Osler Medical Program. Dr. Smith has a long track record of starting innovative programs with concurrent evaluation of their impact on quality and costs, including the Virginia Rural Cancer Outreach Program, the Thomas Palliative Care Program, the Virginia Initiative on Palliative Care, and the Rural Palliative Care Program, among others. He received the National Humanism in Medicine Award in 2000, and in 2000 and 2006 was voted the Distinguished Clinician on the VCU MCV faculty. He has been recognized in Best Doctors in America for many years and is now a Baltimore top doc. He is a fellow in the American College of Physicians, the American Society of Clinical Oncology, and the American Academy of Hospice and Palliative Medicine. In 2012, Bruce Hillner and he received the ABIM Professionalism Prize for their NEJM article, Bending the Cost Curve in Cancer Care. And this year he received the American Cancer Society Trish Green Award for those who have accomplished outstanding research that benefits cancer patients and their families. His current research includes an R01 for a randomized trial of PC versus usual care for phase 1 cancer patients, PC for caregivers of those with HIV/AIDS, patient decision aids that give truthful information, and scrambler therapy for neuropathic pain. Ladies and gentlemen, please join me in welcoming Dr. Thomas Smith.
Thank you, Jennifer. It's wonderful to be here. I'd also like to thank the Cleveland Clinic for breakfast, since I grew up about 60 miles south of the Cleveland Clinic on a dairy farm. And actually had my knee injected there once when I was a high school runner running 100 miles a week unsupervised, which was pretty stupid. I'm going to talk about the benefits of palliative care for us as individuals, as healthcare providers, and us as health systems, and tell you a little bit about how we're responding to some of the crises in medicine at Johns Hopkins. I want to go through what are the decisions you should make as a consumer, as a health system, the benefits of palliative care alongside usual care, what are some of the decisions you should make, a little bit about how to have difficult conversations, talk briefly about depression and some barriers to holistic care. I'm not expecting anybody to read my disclosures. I don't have any commercial disclosures. We're doing some really cool stuff, something called scrambler therapy for pain I'm really excited about because we're doing the first sham-controlled trial. And I just had a flight attendant that I left after therapy yesterday who was able to really walk without pain and without numbness and tingling after chemotherapy-induced peripheral neuropathy for the first time in about a year. I do also have to say that I'm on the test writing committee for the American Board of Internal Medicine, Hospice and Palliative Medicine, and oncology groups. I'm not going to disclose any answers or questions during this discussion, but I'll be available in the hallway afterwards. So when you think of hospice or palliative care, what do you think of? Game over? You think of your patients who are like the frog in the egret's throat, I'm never give up, or you think about rest in peace. You have to know what definitions are of hospice and palliative medicine because they're changing. Hospice goes back to the Middle Ages, during the Crusades. It was a place where people went when they were injured or had nowhere else to go and went to die. Modern hospice was pioneered by Dame Cicely Saunders, who was a nurse and then a physician and quite a pill herself. It's a really concentrating on care, not cure. And it's just for terminally ill patients. So we've taken that and moved it way upstream. In the US, it's bounded by your hospice provider gets about $150 a day, and that's all they get. So it really restricts some parts of care. You have to know what your local hospice is here. I've had the opportunity to work last year with the hospice on Cayman Island, and it's just terrific. I know they provide lovely care here. In Baltimore, when I mention hospice to my inner city patients, they think of it as Joseph Ritchie Hospice. That's an inpatient hospice started during the AIDS epidemic, mostly for black men who are IV drug abusers or gay, and not a place where you would necessarily want to go unless you had to. So toss that idea out the window, Mrs. Green. It's specially trained nurses who will come to your house and help take care of you. They're used to taking care of sick people. They'll help you with your pain. They'll help you with your shortness of breath. They'll have a chaplain and a social worker. They can actually help your family adjust. We have to replace what people know about hospice with modern day. Palliative care is specialized medical care for people with serious illness, just as appropriate for congestive heart failure as anyone else. It's focused on relief of symptoms and stress of a serious illness, whatever the diagnosis. We see everybody who gets a heart transplant. Is that curative therapy? Absolutely. Starting this fall, we're going to see everybody who gets a liver transplant. Is that curative therapy? Absolutely. Is it end-of-life care? For a small percentage, yes. But it's planning and relief of symptoms. The goal is to improve quality of life. It's provided by a team, so we have a doctor, we have 4 advanced practice nurses, we have a social worker, we have 2 chaplains now, we have part of a psychologist, just to provide that extra layer of support. And it's really appropriate at any stage for anybody who is seriously ill. And we have our own Dame Cicely Saunders. At the top left is Nessa Coyle. Top right is Diane Meyer, who runs the Center to Advanced Palliative Care. Everyone knows Princess Di, or at least anybody over the age of 50 knows Princess Di. Tammy Quest, who has 6 emergency room physicians just doing palliative care at the Emory Health System. We wrote this review for the New England Journal, which we're just redoing. We found 6 randomized trials where people got either usual care or usual care plus palliative care. The amazing thing was, there's no harm in any trial. There's always better satisfaction, better communication, better quality of life, better symptom management, less depression and anxiety, despite people knowing a little bit more about what was going to happen to them. It turns out telling people the truth does not make them depressed. Not telling people the truth can make people depressed. And at least 4 now show better survival. So palliative care does not kill people. I've got a shirt at home that says, guns don't kill people, people with mustaches kill people. And I should probably make that up for palliative care. And the amazing thing is, there's not a single trial that shows increased cost. So show me another branch of medicine where you've got 10 randomized trials, where you have better care in every single one of them, better survival in a couple, and the care actually costs less. And we're careful not to emphasize the costing less part. We call it better care at a cost we can afford. Back to some of the decisions you should make as people, as family members, as healthcare providers. It's pretty easy, advanced medical directives. I have a checklist on my screen that I'm typing on while I'm talking to the person. Let's talk about advanced medical directives, durable power of medical attorney. Who will speak for you if you can't? Right now you can obviously speak for yourself, but you've got cervical cancer, it's spread to your lungs. There's going to be a time when you're going to get sicker from this and you might not be able to speak. Who do you want to make decisions? Well, not my husband. Okay, well then who? Let me write it down. We should talk about CPR. We should talk about palliative and maybe hospice care. You said the H word, right? Which leads inevitably to the D word, which is not doxorubicin or docetaxel, since I'm a chemotherapy doctor, but dying. We should talk, do you have a will? Are there any family issues? Any spiritual issues? And let's talk about a life review. How many of you do this routinely for your patients? 1. I know all the hospice people do. Have you ever been yelled at for doing this? Yes? All the time or most of the time? Many times. Yep, you have to get prepared and get people prepared to do it. The advanced directive form in Maryland is really easy. You do not need an attorney. You do not need a notary public. All you need is to fill out this form. You can do it online and print it out. And pretty soon we'll have a registry where it can be uploaded into the clouds. I tried to find the Cayman Islands one, and there isn't one, so we should talk. Because it's really nice if you have this written down. It is, speaking as an oncologist, speaking as a physician, it is so much easier to have these discussions Friday morning at 9 o'clock around some coffee than it is at 3:15 a.m. in the emergency room when you've got families screaming at one another. And these will ask you questions like, should you try to extend my life for as long as possible using every medicine, all medical procedures, or not? The data show fairly clearly that people who die from a clearly predictable death in the ICU, on a ventilator, their families are the ones who have the most distress. Very clear. Other things it'll ask, well, should I have a feeding tube or should I have IV nutrition? Amazingly enough, in every religion in the world, you do not have to do this. Even Pope John Paul II declined a feeding tube when he was dying. I take that as pretty good evidence, at least for Roman Catholics. And then I think we should all get prepared for a worldwide movement for POLST, Physician's Order for Life-Sustaining Treatment. In Maryland, we call it MOLST, Medical Order for Life-Sustaining Treatment. And so anytime I discharge a patient, except to home, I have to fill out a MOLST form. We're the only state where it's mandatory. So it's a big experiment. And the first question is, how about CPR? Do I want CPR or not? So the purple palliative care star there is for somebody who's dying of advanced heart disease, dying of advanced renal disease, dying of advanced vascular disease, dying of intreatable infections. Maybe you don't really want to be hooked up to a ventilator. But that's why we ask, because physicians are terrible at predicting what people want. Turns out that families are even worse at predicting what people want. If you don't have this filled out, your family is more than likely going to be more aggressive than you would want them to be if you'd written it down. There's some really good web-based tools to use. The first is called Prepare for My Care, Prepare for Your Care. It's free. It'll ask you to choose a medical decision maker, decide what matters most in life, what's important to you, what are your goals, and then choose how much flexibility you want that decision maker to have. My wife is here, she's not in the audience. She'd probably say, yeah, keep shocking him. Another time, turn up the machine. Maybe she wouldn't, I don't know. We've talked about it. Tell others your wishes and ask doctors the right questions. The reason you should talk about CPR is it's got its place. It works really well. I was in the Project on Death in America, and I had 3 of my colleagues order up great big bowls of popcorn, and they had to watch 3 years worth of Chicago Hope and ER. And I know some of you in the audience are too young to remember what Chicago Hope and ER were, but they were the first medical dramas. And they watched 3 years worth back to back, and the chance of CPR working in Chicago Hope was 67%. In reality, it's about 15% now, but if you're seriously ill and actively dying, it's close to 0. At MD Anderson Cancer Center, for people who were clearly dying from their cancer, there were no survivors among 117 people who had CPR done. 0. You could always be the first, but the odds are stacked against you. That's why it's important to have this discussion with some facts. It can break ribs. It can lead to the relatives having to turn off the ventilator 2 days later because CPR doesn't do anything to your illness. It does not make the heart failure go away or the cancer go away or the leukemia go away. But if you feel strongly about it, write it down. I tell my patients, I don't care what your wishes are. I just want to know what to do to honor those wishes. Let's discern those wishes. I use the phrase like, if it comes to a point where your body is dying from your cancer, and I use the D word, I don't use it my first visit with people because then I will get yelled at. But I'll use, if you're dying from your cancer, would it be acceptable to just keep you as comfortable as possible and let God and nature take its course? And a lot of people say, yeah, that's what I want. My Aunt Maud was hooked up to a ventilator for 5 days, and it was terrible for everybody. She couldn't talk. She looked like she was suffering. Or they say, I treat young breast cancer patients. If you can keep me alive for 3 extra days on a ventilator, please do. That's why we ask, because we're terrible at guessing. So, you should talk about palliative and maybe hospice care. I tell people to have a will. I actually start with that question because it's so easy. I'll say, I'm a cancer doctor. You've got congestive heart failure. Your cardiologist asked us to see you before you get considered for a heart transplant. And I can tell you from taking care of sick people that there's a list of about 7 things you should do. We're calling this the Johns Hopkins checklist. And I start with a will. Do you have a will? Because it's a safe, easy question. And then, do you have a living will? Do you have a durable power of medical attorney? Can we talk about palliative care and hospice? Are there any family issues? And people will say, well, no, not really. And then the wife will you haven't spoken to your brother for 17 years. Or you've got a daughter that you haven't seen since she was 5. Maybe now's a good time to do that. And I'll say, thank you for saying that. Let's move that upstream. How many times have you heard, if I'd just known what was going to happen to me, I would have done things differently? I see a few heads going up. So my advice is do these things while you are well. Do these things while you have the energy and the ability to travel. If you want to go back and see your hometown, if you want to go back to church or synagogue, if you want to go to a Little League game, do it now. Any family issues, any spiritual issues. And let's do a life review. The interesting thing that people are not aware of about hospice is that the 2 studies out of 2 that have been done show that people who use hospice live longer. How many knew that? A couple. How many thought hospice patients live shorter? Nobody's going to raise their hand now. But what if you had a team whose job it was to manage your pain, manage your shortness of breath, help you maintain your flexibility at home? That really helps people. It helps your immune system. It helps you avoid getting a deep vein thrombosis and pulmonary embolism. Helps avoid getting pneumonia. And for congestive heart failure, the length of time you're alive longer is almost 3 months. If this was a drug, people would be down at the FDA demanding it. Won't my doctor tell me when I'm that sick? The answer is no. It's really hard for us. It's very hard for oncologists, cardiologists, pulmonologists, even nephrologists to look another human being in the eye and say, I'm really sorry, but medical science doesn't have a way to make you live a whole lot longer. In fact, 75% of oncologists will tell a person they have incurable cancer, but then, quote unquote, it never came up again. Even when the disease, you had a great response for 8 months for first-line chemotherapy for lung cancer, that's the time to have the discussion when the disease is growing again. Only about 25% of people will have a discussion with their oncologist about actual prognosis and impending death, and it's really late. In fact, in the United States, most of the time it's not with the oncologist, it's with the hospitalist admitting them to the hospital. If you can move that discussion up a couple of months, it changes everything. It gets hospice involved. If you have that discussion about impending death a month before you die, your chances are 50-50 you're going to die in the hospital. How many people want to die in the hospital? How many people want to die at home surrounded by their family, friends, dogs, cats? Okay, bottle of rum, K-beer. Right. It's amazing that's worldwide. And yet, if you have that discussion 2 months before you die, so you can plan, get a structure in place, call our wonderful hospice people here, your chance of dying in the hospital goes from 51% to 19%. So show this slide to oncologists. There's no easy way I can tell you this, so I'm sending you to someone who can. And we did some research that showed that it's actually easier for patients and families to have these difficult discussions with somebody a doctor they've never met before, which is fascinating. So if you're getting called in, oh, it's another Smith admission, poor interns down in the emergency room at 3 o'clock, it's another Smith admission, metastatic breast cancer, mets to brain, lung, liver, bones, and he hasn't had any discussion about advanced care planning or directives or code status. Recognize that it may be easier for that patient and family to discuss it with you, who they've never met before, than with their oncologist or their cardiologist that they don't want to disappoint. It's a fascinating paradox. So anybody can have these discussions. And then we moved to family, spiritual care, and then what my friend Harvey Chochnov, who's a psychiatrist, calls dignity therapy. Let's write down what you want to be remembered for. How many times have you heard patients say, well, I just wished I'd written everything down and now I'm too sick? Most people living here, like most people living in Baltimore, most people living in Winnipeg, Manitoba, where Harvey practices, have an interesting story to tell. And it's much better if you can tell it while you can. If you got some things you want to hide, it's a lot easier to hide them while you're still alive, too. How do you want to be remembered? What are you most proud of? What have you accomplished in your life? When did you feel the most alive? We actually do this with our patients. And we hope to start a program where we do it routinely with people, particularly young moms who are dying of breast cancer, cervical cancer, ovarian cancer, because they have so many roles to play. We want them journaling with their kids. We want them making birthday messages, go off to high school messages, first time you get busted messages, things like that. A little bit about palliative care. This is a summary slide. We're working on another guideline for the American Society of Clinical Oncology, and these are the 10 big trials. OS is overall survival, so these are all randomized trials. And 2 of them in yellow show that patients who got palliative care didn't live quite as long, but it wasn't statistically significant. And then the others, you read longer, 5 months, longer, 3 months, longer, 15 out of 100 at 100 days, longer, 6 months, longer, 6 months. If you've got a team who's helped relieving your pain, keeping you active, keeping you breathing, screening for depression, helping you with spiritual care, the data is accumulating that you'll actually live longer rather than shorter. And in the middle, the patient experience, every single one is positive. The other fascinating part in green is that it usually costs less. And there's not a single trial that shows that concurrent palliative care costs more. Show me another branch of medicine that's the same for. But it can't happen on its own. So Betty Farrell at the City of Hope and I are promoting this concept called TEAM, T-E-A-M, and the T stands for time. It takes time. It takes an hour a month. Doesn't have to be the doctor. In fact, many doctors are not very good at this. Nurses are probably better at it. Advanced practice nurses are even better at it because they get more training and they don't have to generate the income the same way that I do. I can't do this when I'm in the oncology clinic and I've got a 12-minute visit to discuss chemotherapy and then 12 minutes for documentation. I can't do it. It can be in person, or it can be by telephone, or by Skype, or by FaceTime, but it has to be structured. I'll show you some of the things we do during those visits. And the E stands for education. In the Harvard trial that showed people with lung cancer who got palliative care lived longer than those who didn't, they talked about what's your understanding of your situation? Do you think you can be cured or not? And more people understood that they couldn't be cured. Were they more depressed or less depressed? They were less depressed because they could plan. So in this hour, you concentrate on symptom management, communication, what are your options for treatment. I never tell people, well, you shouldn't do that chemotherapy. I'm not their oncologist. Here's some questions you should ask your oncologist. Here's some questions you should ask your cardiac surgeon. We concentrate on advanced care planning and then use of hospice. We try to arrange a hospice information visit for somebody who has a serious illness that we know is predictably going to take their life when they've got 3 to 6 months or even longer to live. That way it can be a planned transition rather than treat. Oh, you're really sick, can't come to clinic, time for hospice. I'm going to call hospice people, and the person died 3 days later. That's not optimal. And then formal assessments. We use the Edmonton Symptom Assessment Scale. Are you bothered by pain? Are you bothered by nausea? Are you bothered by anxiety? Are you bothered by constipation? Are you bothered by depression? Oh, you are. If somebody says yes, that's a great way to say, well, what makes you most depressed? What makes you most anxious? One of the persons I saw yesterday said, oh, it's my 3 kids, none of whom are really doing very well with mom being sick. One of them is My husband found out he had a love child. He had to get paternity tested. He scored 99.9999, best score he ever got on a test. That person's not doing very well, and my 19-year-old has some major problems too. If I'd not asked the question, I'd never found out what she was hoping for, which was to get some more time so she can help get those kids straightened out. And I ask, are you a religious or spiritual person? I tell people, you want me to know your spiritual needs. Turns out that about 90% of cancer patients, at least, want their healthcare team to know their spiritual needs. Only about 6% of us ever ask. That way I can make a referral to a chaplain, I can encourage them to go back to synagogue, go back to temple, go back to church. I tell them, you don't want me managing your spiritual care needs. Me managing your spiritual care is a ticket to hell in pretty much every religion that I know. But you do want to ask, is religion or spirituality important to you, and how would you like to address it? And then we do the psychosocial distress thermometer, we ask some goal setting, and we do some legacy work if appropriate. And we are rolling out, and I didn't have time to get them printed out for here, the Johns Hopkins Palliative Care Communication Tattoo. It's a temporary tattoo that goes on your inner forearm here. You can see there, it's on Paula's inner forearm. Because these are such difficult questions to ask, and it's so hard to even get started, I have them here on my forearm. You can make them permanent if you want. What's your understanding of your situation? How do you like to get medical information? Oh, you're one of those people who wants to know everything. Okay. Or, oh, you don't want to know any bad news. Okay, tell me more. Is there somebody else in your family who I should be talking to? What's important to you? What are you hoping for? See this little hope button on my lapel? We're in a campaign at the Cancer Center that every patient should be asked at every visit, what are you hoping for? What are you hoping for? Open-ended. And have you thought about a time when you might be sicker, when you might need a living will or advance directive, a little motivational interviewing techniques there? Works really well. Then you have to have a management plan, set protocols by an interdisciplinary team that meets regularly. We think having a team talk about you in our interdisciplinary team meeting once a week or once every 2 weeks is probably the most important thing that can happen. Because that's when we get everybody together to think about, well, what does this person need to get from step A to step B in their life? I'll show you a little bit of the evidence. I promise not to bore you with all 10 trials, but they're all sort of reproducible. This is Project Enable 2, Educate, Nurture, Advise Before Life Ends. It was done with 322 cancer patients in New Hampshire and Vermont. And they got their usual care, half of them, and half of them got their usual care plus 4 visits with an advanced practice nurse. How many of you are advanced practice nurses? Okay. Well, you're magic, whatever you do. Because they had 4 visits. The first was, tell me the 3 things that bother you the most, and we're going to work on those today. The second was, tell me the things, I'll give you a list of 10 symptoms, and you tell me which ones bother you, and let's create a plan for communication. The third was on some life goals, and the fourth was managing symptoms and communicating with the healthcare team, and then they had once a month visits by phone. This is the survival curve. So starting with 100% of people alive, the bottom curve is the people who didn't get palliative care. The top curve is the people who did get palliative care, and you can follow the palliative care purple star there and see that it was significantly better at a year. Far more people were alive, like 15 out of 100 were alive when they had this other team helping manage their symptoms. She wished she would have stopped the trial at 1 year, because then she could have taken it to the FDA and said, here's a new drug we have that I want to get approved for $12,000 a month. And then Jennifer Temmel did this trial with lung cancer patients at Mass General, the Massachusetts General, a really good place to get your lung cancer care. And they met once a month with the palliative care team for an hour. That was it. It's not rocket science. It's not a brand new drug. They met once a month with the palliative care team. The top curve is the group that got, in addition to chemotherapy, they got a palliative care consult once a month. Some of the reasons they lived longer, they had better symptom management a little bit. They had better planning. They knew a lot more what was going to happen to them and were able to admit it, and they got less intravenous chemotherapy in their last month. So it could be that chemotherapy for the 4th and 5th line in lung cancer therapy actually kills people rather than helps them. And this is Project Enable 3, done by Bernie Bakaitis, again at Dartmouth in New Hampshire, just published in the Journal of Clinical Oncology. This was 6 visits with an advanced practice nurse versus no visits with an advanced practice nurse. And it's, again, what is that? That's 15 people out of 100 alive at a year. More. Additional. If you're one of those 15 people, that's a big deal. There are very similar data from Irene Higginson at King's College London for people who were suffering from advanced breathlessness with COPD. The curve looks almost identical to this. What they did there was they gave them a fan to blow cold air across the nose. They gave them a poem to recite when they got anxious, rather than getting, I'm anxious, now I'm more breathless, now I'm more anxious, now I'm more breathless. They gave them a poem to recite to cut down a little bit of mindfulness, and they gave them a little bit of morphine to help with their breathlessness. It made a big difference. This is Betty Farrell's data from City of Hope. Again, the purple palliative care star there is a group that got palliative care visits once a month in addition to chemotherapy. And it's better. Survival is better. All right, go back to the decisions you should make as a health system. I work with a Center to Advance Palliative Care that Diane Meyer started, and we've shown that palliative care quality improves and that costs are reduced. You help symptoms, quality of life, length of life, family satisfaction, even physician satisfaction and nurse satisfaction, and that the cost goes down. It goes down because people use less cost per day in the hospital. They use the ICU less, they use the emergency room less, the 30-day readmission rate is less. Even in-hospital mortality may be less. Concentrate on explicit goals of care. Rather than avoiding discussions about what's going to happen to you, we ask, well, do you want to have a discussion about what's going to happen to you so that we can check it with reality? End up doing fewer tests and procedures, end up transferring people out of the ICU. So what I'm hearing you say, and your family can tell me if it's wrong, is you really want to get home to be in your own bed for your last days. And you'd like to get off this ventilator so that you could get home to be in your bed for your last days. Okay, let's see if we can work on that. Shorter length of stay and more and earlier use of hospice. This is the data showing all the trials where people either got usual care in the blue or usual care plus an interdisciplinary palliative care team in the green. The striking thing is when you have an interdisciplinary palliative care team involved, the cost is always less. That's not why we got into this. We got into this to relieve symptoms, but it's amazing that it helps to improve survival in addition, and it seems to reduce costs. So every government that does both insurance and healthcare should be looking at this. Like Kaiser Permanente is a private group in the US that does insurance and healthcare provision. They did the first 2 big randomized trials that showed that patient satisfaction was better, quality of life was better, people lived as long, but it saved them money. So they do this in every place where they are. We have a Veterans Administration for care of US veterans. It does exactly the same thing there. And that's important because it's a fixed budget. When you have a fixed budget, you don't get more when it's gone. Fixed budget, you have to use it wisely. They compared patients before and after, and when palliative care was done, the total cost savings were about 10 or 20% less. That's a lot more money you can use for new drugs and new advances. Less likely to be admitted to the ICU, quality of care and satisfaction with care was better. Medicaid is another example of a fixed budget program. If New York State universally adopted palliative care in all its hospitals, they would have savings of millions of dollars, which they could then use to help with more uninsured. Again, this is not the reason to do palliative care, but it's a nice ancillary argument. So what are we doing at Johns Hopkins? We've got some really interesting pressures. Our reimbursement is now capped by the state. We have 1,000 more admissions, it's on us. We don't get paid any more. We don't get anything for 30-day readmissions, no payment at all. We've got some really new good treatments, particularly immunotherapy, that have a lot of side effects that end up with people being in the hospital, so that's another big pressure. And we have rapidly rising drug costs like everybody else. And we have a long history of let's do everything possible to save every individual patient rather than thinking about the whole health system. So we're trying to think about how you do palliative care in the office. And I'm happy to send these slides and send the articles to anybody, just email me. We do ask, tell, ask. What do you want to know about your situation? We tell, and then we ask again, well, now that we've had this discussion, what's your understanding? We're trying to do that not just at the beginning, but at every inflection point for the disease. And so that at each transition point, we redo that conversation. We do a hospice information visit. And we're doing some very specific outreach. So we're trying to partner with doctors who don't get this. I am an oncologist. I would bet at least a third, if not a half of oncologists are very uncomfortable with all these discussions. A lot of us. I used to be, I still am with some of my patients. It's really hard to have these discussions. So we're reaching out to some of the oncologists who aren't very good at it and saying, we'd like to help you. We understand how difficult this is, and we'd love to see your patients right alongside with you. Works pretty well. One of the lung cancer doctors came over and said, I'm not very good at having these conversations, and I know they need to be had, and I could really use some help with managing people's shortness of breath and pain, all that stuff too. Would you mind seeing everybody? What do you think I said? Nah, you're on your own, buddy. No, so we now see pretty much all of his patients, and we try to see them early in the course because the data are now accumulating that will help them through the course and actually may help them live longer. We're feeding back information. So we just looked at people with brain tumors, glioblastomas. Talk about a disease that takes away your personhood, about a disease that takes away your ability to make decisions. This is one, because it's growing in your brain. And you would think that 100% of these patients should have written down advanced directives, but it's not anywhere close to that. Think like a tenth of that. So we're now giving that information back to the doctors, trying to give them the tools to improve their performance. Same with hospice use. We are now embedded in the oncology clinic. We do a lot of work in the gyn-onc clinic because those patients have so many needs. We have a lot of people with substance abuse issues in Baltimore who often have cervical cancer, vulvar cancer, et cetera. So we're embedded there, co-managing those patients. We're rounding with oncology to get earlier access to patients, and we're now embedded in the emergency room. We know that the sooner you can get in, the better you can help with people's symptoms, and the sooner that their cost gets lowered as well. This is our emergency room work. I'll skip that. I will just show you that we contributed about $4 million to the Hopkins bottom line last time by a little bit of professional fees, but also by avoiding costs. We've also had hospice referrals go up 400% in the past 4 years, literally 100% a year, just by being advocates for this. Skip this one. And that's important because in the United States, at least, fully half the patients who should get hospice never use it. So we're on a mission to correct that and make us be much better than average. To do that, we're going to need to target the highest risk people, ask people what matters to them, support families and other caregivers, and we're moving to 24/7 access, just like hospice does, but with palliative care sooner, so that we're shifting from disease-directed therapies to increasing use of palliative care, this hospice information visit, and then a hospice transition visit when they get sick and there isn't any more therapy that can be done. Talk about some barriers to mental health. One of the big things is getting doctors to ask about depression. It turns out that asking, are you depressed, has close to 100% sensitivity and specificity for clinical depression in Canada. So you can ask people, are you depressed? And take it from there. You have to distinguish it from demoralization, which is hopelessness and helplessness. That's a good thing for the chaplain to help with. Apathy, medical illness. We ask about religion or spirituality. I already explained that most people want us to know. We actually have a little radio button on our intake history and physical that pages a chaplain. Quick note about neuropathic pain. That's one of my interests. There's not a whole lot that works for chemotherapy-induced peripheral neuropathy. One of the things that may work is 1% menthol cream twice a day. One small trial, 82% of people said it helped. Another is something called baclofen amitriptyline ketamine gel. It helps on the hands, doesn't help quite so much on the feet. But don't give up on neuropathic pain. Keep trying to do things that actually help. Skip that. Ginseng, American ginseng, helps for fatigue. You can see the scores for physical fatigue went down with this herbal product. $14 a month. Not huge, but it's enough to help. Psychostimulants help a little bit, things like Ritalin and modafinil, but they only help if your fatigue is really terrible. Otherwise, don't use them. But if you use them, you can use them for 2 days, and that'll tell you whether it works. And then we're sending all our patients to think about some mindfulness research. I'm a breast cancer doctor, so I produce chemo brain and fatigue. One of the things that works is yoga in randomized clinical trials. The other is mindfulness research. I send people to the UCLA Mindful Awareness Center. You can get free meditations, and that helps with fatigue, pain, depression, insomnia. It actually helps reset your brain waves and helps normalize your EEG. Skip that one. So my conclusion, this is with my nephew there, do have these discussions when you're well. Do document your choices. Help your patients document your choices. Doing so will help everybody live better, possibly live longer, and help ensure that your choices will be honored. Think about mindfulness and absolutely think about exercise as part of a structured regimen. Thank you.
Thank you.
Questions? Yep.